Well, good evening. My name is Ryan Carlson. I'm a colorectal surgeon who started here in Cape Cod at Cape Cod Hospital just a month ago in early February. And thank you for tuning in for this Wellness Trails event. This is called Guard Your Health Like Your Finances. Colorectal cancer prevention starts with screening. So I wanted to liken colon cancer screening to the choice to do it kind of like what your financial advisor and how they're going to counsel you. Obviously, they want to help you navigate risk. They would just love for you to get rich, but they really, really don't want you to lose everything. That'd be terrible. So let's talk about odds for a second. So if you're rolling dice, the chance of rolling a 1 is 1 in 6. And if you're going to roll 2 dice, the chance of rolling 2 ones or snake eyes is 1 in 36. So that's about 2.8%. We'll call it 3%. So just imagine this for a second. So let's say someone hands you 2 dice and tells you to roll for a day off of work. A paid day off of work. What could be better? And they tell you that 35 out of 36 people win. That's the best. What could be better than that? The only catch is if you lose, if you get snake eyes, they get everything. They get your house, they get your car, they get your 401k, your kids aren't going to college, they get everything. So your financial advisor is going to suggest that you don't roll the dice for a 1 day off of work if you have to bet the whole house, bet the farm. How does that correlate with colon cancer? Well, 4% of Americans are going to get colon cancer. It's not 1 in 1,000 or 1 in 1,000,000. It's not like getting bit by a shark in the bay or getting struck by lightning. It's 4% of us will. But the great thing is that a colonoscopy, and other types of colon cancer screening also, they can reduce your risk of dying from colon cancer by 80%. So 80% times 4%, that's that snake eyes. It's about 3%. So if we do colonoscopy, we'll end up saving about 3% of the people who we scope. So your financial advisor says, minimize your risks, maximize your benefits. Don't bet everything rolling dice, and please do get checked for colon cancer. And who should get checked for colon cancer? Everybody who's 45. That's the age. I'll talk about why we picked that age. It wasn't out of the blue. It used to be 50. But colon cancer is happening at younger and younger ages now. So first, a quick biology lesson. Now, everyone knows this from biology in high school somewhere, but it's been a minute for a lot of us. So let me just tell you that you've got about 18 feet of intestines between your lips and your anus, and the colon is the last 4 to 5 feet of that. So as the food goes down into your stomach, it kind of looks like food still in the stomach. We all know what that looks like if we've had a throw up before. The food goes down to the small intestine, like 15 feet of it. And at the end of that, it doesn't look like food anymore. It looks like kind of a tanned paste. And like 95% of the calories have been removed from that food at that point. But a lot of the toxins are still in there. And the food makes it into the colon, or the large intestine. Those two words mean the same thing. And just the last 5% of the calories get taken out, removed from the food. And a lot of the toxins will come out the other end. But some of the toxins will be concentrated there in the colon, and that's one of the reasons we'll get more colon cancer. Then you don't hear about small intestine cancer screening. There's not a lot of small intestine cancer. There's 100 times less than there is of colon cancer. So we don't screen for that. Stomach cancer, some cultures have a lot of stomach cancer. Japan historically has had a lot, so they do screening for stomach cancer. But we have a different diet, and so we tend not to screen for that. So here's kind of the key question is, why do we get colon cancer? Every single person who comes into my clinic wants to know, why did I get this? Was it because I smoked in my 20s? Was it because I drank too much in my 30s? Why did I get it? Well, I like to remind them that, first of all, 4% of us get it. It's common. It's not 1 in 1,000,000. And second, this knocks people's socks off, but our colon cells, they only live for 3 to 5 days. That's it. 3 to 5 days and you got all new colon cells. So your cells have been making copies of copies of copies for decades and decades. And probably everyone who's interested in colon cancer screen and tuning in used to own a VHS. Well, remember what happened to those copies of those VHS tapes. You recorded the Super Bowl to watch it later, and then your buddy wanted a copy, so you made a copy for him, and then he made a copy for his buddy. Well, by the 3rd or the 4th copy, that film wasn't looking so rich anymore. It's pretty fuzzy. And that's kind of what happens with our cells. We're making copies of copies and copies for our whole lives. The colon actually has, different experience on different sides. So the left side of the colon will get different cancers than the right side of the colon. We call it all colon cancer, but genetically it's different. Why do we get colon cancer? Well, there are lots of toxins in our food. People who have a high fiber diet, we think that the fiber does two things. One, it flushes those toxins out, and so they go more regularly. Get the toxins out of the body, get less cancer. That makes sense. We also think that that high fiber diet will bind some of the toxins so that it's just trapped in the food and not going through the wall of our colon and causing damage to those cells. There are also toxins in our own body. Our body's guilty too. So the liver makes bile acids, and those bile acids make it through the small intestine and into the colon, and those bile acids are passively absorbed through the colon wall. And that's pretty efficient. So most of the bile acids are removed in the right colon, and the left colon doesn't see as many bile acids. So all this means that we kind of get different cancers on the left than the right. Genetically speaking, it's more the chromosomal instability pathway on the left, and it's more the microsatellite instability pathway on the right. And this can have some effects about how we treat colon cancer too, which chemotherapy regimens are going to be more effective. So why do we get colon cancer? Well, we get polyps. So our cells are making copies of copies and copies our whole life, every 3 days. And some of these aren't so good. All of those cells, they're programmed. They're programmed to die after 3 to 5 days. Well, what if the genes that program the cells to die don't work? They don't die. And so those bad cells are making copies of copies and copies. And the copies start to get weirder and weirder. And you get enough of those weird copies, and you can actually see them. It's a polyp. So on the left of your screen there, you can see some small polyps. Those cells are pretty weird looking, but not so weird that we call them a cancer. And on the right, they've been making more copies of stranger cells over and over again, and finally we call it a cancer. Genetically, how does this happen? Well, with all these copies being made, there's got to be our cells are pretty good at it. For only 4% of us to get colon cancer, with all those copies, our cells must be doing something right. So there's all this genetic cellular machinery inside of our cells to proofread those copies. And some of those are called mismatch repair genes. So as our cells are making copies, there are these enzymatic protein proofreaders to make sure the copies are good. And if those break down, we might still be okay. But then if another copy of those proofreaders break down, then we're on a track that may lead to polyps, weirder polyps, and eventually a cancer. I like to point out this graph for people because it's kind of interesting that our cells are really good at making copies until that inflection point on the graph in the middle of your screen. That's about when most of us are done making babies. So genetically, we're programmed to be pretty good at making those copies of cells with high fidelity until our bodies are kind of done making babies. And then the graph goes skywards. Then we get a lot of colon cancer after that. So again, 4% of us will get colon cancer. Yeah, probably. But 80%, this colonoscopy will reduce the death from colon cancer by 80%. This is how important screening is. Ideally, we're doing colonoscopy and we're taking out polyps before it becomes a cancer. That's a neat trick. But if we're not, if we're just finding the cancer early, that's also great. These lines on your screen, the top ones, are the stage 1 and the stage 2 colon cancers. And you see that the chance of being alive from that 2 years after you get the cancer is extremely good. We're very, very good at curing early stage colon cancer. As you get stage 3, that typically means that the cancer has spread from the colon wall into the lymph nodes. And we're pretty good at curing that. We're curing around 70% of that. But that bottom line is the one we really would like to avoid. That's the distant spread. So the cancer has left the colon wall, it's gone through the lymph node barrier, and now it's in the liver, it's in the lungs. We have a harder time curing that. So those are most of the deaths from colon cancer. And that's why we want to catch it early or prevent it from happening in the first place. So colonoscopy is the gold standard for preventing colon cancer. There are lots of other screening types. I'll encourage you to get any type of screening for colon cancer because it all works okay in the end. But this one's the best, and so I'd like to tell you about that. I'm going to overshare here. My wife won't be happy later, but in preparation for today's talk, I got a colonoscopy myself just yesterday. That's not a joke. I'm 45 years old, and I got mine yesterday. And the nurses who helped me with that will tell you two things. One is that you don't get funnier when you get medications. It doesn't happen. And two is, it's just not that big of a deal. You come in, I think it was about 15 minutes. Even the washout, not that big of a deal. I drank some stuff the night before. I woke up early, drank some more stuff in the morning. I saw 12 patients in clinic. I got the scope at 1 o'clock. It was all okay. So that picture on the right is an actual picture from a colonoscopy. There's a polyp there. That polyp probably doesn't contain a cancer, but it could at that size. And you can imagine how we can just put a snare around that polyp, take it off, and polyp cured, potentially cancer cured, just with that. And if it's not a cancer yet, by removing it, you bet we're going to prevent that particular colon cancer. So that's why colonoscopy is the gold standard. It has the ability to prevent some of the cancers, and it's also the best at detecting. But I am not going to discourage any type of colon cancer screening, because anything on this list is better than nothing. One way is the yearly stool blood test. What's tough about that is that it's yearly, and how many of us are really going to send our stool in every single year, for 30 years? It doesn't happen that often. People forget a year, and after you've forgotten a year, you forget 2 or 3 years, and suddenly you're not screened anymore. And in the best setting, that test will detect about 72% of those cancers early, not 95%. On the left side of your screen is colonoscopy. The purple bar represents the cancers that we're detecting, and the other bars represent polyps that we're detecting. So you see that the stool blood test is not finding many polyps at all, and it's at about 72% of the cancers instead of 95 or even higher of the cancers. There is a CT scan possibility, which is pretty good for detecting both of them, but that's getting some radiation, and you have to do it more often than colonoscopy, and you still have to wash out your colon for that. And you still have to get something up your backside because they have to pump a lot of air in there for that CT scan. The one on the right has been getting a lot of attention. That's basically Cologuard. It's a DNA-based stool test. And it's detecting over 90% of cancers by sending your stool in. Have to do it every 3 years is my understanding, so it's not a one and done for 10 years like colonoscopy tends to be. And while it's very, very good for finding colon cancer, it really drops off for finding those polyps. There's one more thing that I'll mention, and that is this blood DNA cancer-based test. And that is, I won't discourage it, but it's not the best screening test for colon cancer because it's only detecting those early cancers about 20 or 30% of the time. So the blood DNA cancer screen is not ready for prime time for colon cancer screening yet. How are we doing in the country for colon cancer screening? Well, about 40% of us don't get screened for colon cancer. In Massachusetts, we're a bit better. Only 30% of us don't get screened. Well, we'd like it to be 97% or higher. 97%, that's the percentage of drivers in Oregon who wear their seatbelts routinely. Massachusetts, we're not quite as good, 80%. But that's pretty good that 97% will buckle their seatbelts. And for what risk are they doing that? Well, the chance of an American dying in a car accident is 1%. But the colon cancer risk is a heck of a lot higher than that. I've told you several times, 4% of us get colon cancer. So why doesn't everyone get screened? We know the reasons. Unfortunately, if not everyone, if you don't have a job, it can be harder to have insurance. It can be an expensive thing. There's time off of work to think about. There's the ick factor. I get that. People are worried. But most of all, it's excuses. And most of them are bad excuses. And I've heard many of these. So let me run down the list with you. It's, I feel fine. I don't have any symptoms. Cancer doesn't run in my family. I eat healthy. I don't smoke. I don't drink. I exercise. Something's got to kill you in the end. It's a scam. They're just out to make money. Why should I get a test that's just going to tell me I'm going to die? I don't want to hurt. I don't want to feel any discomfort. Oh, my aunt got her colon perforated during a colon cancer. They put a hole into it. So we hear all these things. We'll start from the top. The I feel fine. I don't have any symptoms. Well, go back to this picture. There could be a little cancer hiding in that polyp there. Why wouldn't you feel fine? It's not blocking the tube, so you're not obstructed. You're not having crampy abdominal pain. You're not passing any blood. That thing's not bleeding. So why wouldn't you feel fine if you have an early cancer? Everyone feels fine with an early colon cancer. It doesn't run in my family. Well, most of these are sporadic. So we do always ask about family history. We do want to know if your mom and dad had polyps. But in the end, that biggest piece of pie there, 65% of these cases are sporadic. No one in the family had the colon cancer. There's no gene we can point to that's guilty. So that excuse I'm not buying. How about the I'm healthy, I eat healthy, I don't smoke, I don't drink, I exercise. It is true that red and processed meat, eating a lot of those can cause more cancer. More alcohol can cause more cancer. Alcohol is in your liver. As it's being detoxified, it turns into something quite toxic, the aldehydes, and the aldehydes can cause DNA damage and cancer. Excess body fat can contribute to this. And there are a lot of healthy activities that do decrease your risk, being physically active, having a healthy weight, eating whole grains, having a lot of fiber in your diet. All those do improve your health. I'm not going to discourage any of those. But I want you to know that each one of those tends to change the risk of getting colon cancer by about 10 to 30%. Can a couple of them add up? They can, but they don't add up to 80%. It never works that way. And so really only a colonoscopy is going to decrease the chance of dying from colon cancer by about 80%. Something's got to get you in the end. Well, that's true, but last month in my clinic I had a couple 30-year-olds with colon and rectal cancer. So these years after our reproductive years are pretty special, and I think people are tuning in know that. So we want to extend those good years. It's a scam. They're just out to make money. Your insurance company begs to differ. Most of them were not so thrilled about colonoscopies being mandated from the Affordable Care Act. So that was a very expensive mandate from the federal government that the colon cancer screening had to be free for everyone with insurance. And that was a very big deal. Well, why should I get a test that's just going to tell me I'm going to die anyway? We don't get tests like that. And look at this graph. We're trying to find the cancer early, and look at the cure rates and the survival from the early detections. We do fantastic. And even the people we have a harder time curing, it's much harder to cure a stage 4. While we're not curing them, we might be adding years of healthy, high-quality life to them. So we do want to detect this stuff. I don't want to hurt. I don't want to hurt either. That's why there's a lovely medicine. Most people use it. It's called propofol. And it turns the experience from one of going to the dentist and some discomfort here and there, tolerable but maybe uncomfortable, to a lot of people say it's the best sleep they had. It's the best half-hour sleep they've had. They wake up feeling pretty refreshed. So you don't want to hurt. You don't have to hurt. My aunt's friend got her colon perforated during her colonoscopy. It is true, perforations can happen. The number's somewhere in the neighborhood of 1 in 6,000. So could it happen? Yeah. But what's 1 in 6,000 compared to 4% of us getting colon cancer? They're orders of magnitude different. And I'm seeing these people in the hospital if they do get the rare perforation, and I'm not operating on most of them. I'm having them in the hospital for a couple of days, giving them a clear liquid diet, giving them some antibiotics, making sure that it's usually a tiny, tiny hole seals, and then we send them back home. So we hate the perforation, but they're extremely rare, and I don't think it's a great reason to not get a colonoscopy. So, in conclusion, your financial advisor wants you to minimize your risks, maximize your benefits, and please do get checked for colon cancer. Thank you for tuning in. Some of you did ask some questions, so let me go through these. So why is colorectal cancer impacting younger individuals? That's true. So overall in the country, the numbers of colon cancer per year has been declining, and that's been an important trend, and we think colon cancer screening is the biggest part of that. But the annoying trend, more than annoying, is that it's starting to impact younger people, and it's getting them, sometimes before the screening recommendation. I showed that graph of how the colon cancer incidence doesn't really skyrocket until after our reproductive years. But some people are coming in their 30s and 40s with colon and rectal cancer. We don't 100% know why that's happening. We think that our environment is the cause. We think that our diets are probably getting worse. I told you how important fiber is. 100 years ago, it was extremely difficult to get 2,000 calories in a day without getting your 30 grams of fiber in every day because food wasn't processed. But now our food is processed, and what they kind of mean by that sometimes is just taking the fiber out. So now it's extremely easy to eat 2,000 or 3,000 calories and get 5 grams of fiber in your whole day. Well, we're supposed to, our systems are tuned to run on 30. And I tell people that's kind of like running your Ferrari on E85. It's not meant to run on E85. We're supposed to run on 35 grams of fiber or so. And the other thing is, what other chemicals are we being exposed to? You know, forever chemicals are always in the news. It's hard to know what impact those forever chemicals are on us, because even if you take old stored blood tests from people living in China in the 1950s, that blood still has forever chemicals because these were being produced in that time and they were kind of worldwide. So it's a bit hard to find populations that weren't exposed to those. But we do think it's from the environment. If a polyp is found during a colonoscopy, are certain types of polyps more concerning than others? There are the extremely safe polyps. That's called a hyperplastic polyp. And if I'm doing colonoscopies and I take out a couple hyperplastic polyps, you still get 10 years before your next exam. The next safest polyp is probably a sessile serrated adenoma. Then it goes adenoma. If I find one or two small ones of those, I'll probably give you 7 years before your next exam. You're not doomed to come back in 3 years. And then there are the more concerning ones, and they're called tubular villus adenomas or villus adenomas. And those are known to be more aggressive and to have more people who develop those polyps get cancer later on. So all polyps are not created the same. Great question. What are the known symptoms of colorectal cancer? And when should someone see their doctor in between colonoscopies? That's a great question. You know, colon cancer can do a couple things to raise a red flag to alert us that it's there. One, it can bleed. Trouble is, most bleeding is not colorectal cancer. Most bleeding is hemorrhoid bleeding. But bleeding is one thing you could see. There's different types of bleeding too. There's bright red blood that drips into the toilet, and that's a bit more likely to be hemorrhoidal bleeding. And there's kind of the dark, maroony, really bad smelly kind of bleeding, or the darker, really malodorous bleeding. And that's a bit more concerning because that's probably not your hemorrhoids making that kind of bleeding. That's probably blood that came from higher up in the colon that had time to get fermented, which is a smelly process. So blood is one thing. And then colon cancer can obstruct. It can block the pipe. If you got the sprinkler on outside and someone kinks that hose, the flow is not going. And in our GI system, if the flow is not good and going, we're getting bloated, our bellies are distending, we're getting crampy abdominal pain. And also by narrowing the pipe, it could thin our stools. So instead of having a normal diameter stool for you, it could start to get skinny, like a marker or like a pencil, and that can be a concerning symptom. Can you explain the colonoscopy process, including any prep or recovery? Yeah, definitely. So I want you to follow your doctor's orders. Some of these preps, they let you actually eat breakfast. Some of them let you eat lunch. A lot of them tell you not to eat anything the day before. So you're on a clear liquid diet for some or all of that day. And then you're going to start drinking your prep solution. And there's a whole big variety of them. Kind of one of the first tried and true one was a big jug, the 1 gallon of what's called Go Lightly. Didn't taste so great. And then we kind of went to the Miralax prep, which was half a gallon, and it tastes like Gatorade, so that tastes a bit better. Then we had a hard time sourcing mag citrate that went with that for a while. Suprep is a common one. That's, I think it's a couple of quarts that you drink. Sometimes it's one in the evening before you go to bed, wake up, have another one at night. But you're drinking the liquid, or sometimes people are taking pills. But even with those pills, you need a lot of liquid because you got to flush out the system mechanically in that way. So you're drinking a lot, you're going a lot. For some people, it's a couple hours of going. Maybe they go 5 times over 2 hours at night and 5 times over 2 hours the next day. Other people drink the stuff and they don't go until the next day. It doesn't happen an hour or two later. It happens 12 hours later. All of our systems move at different speeds. So you get cleaned out. At the end of the day, you want to be able to see through the toilet. That's what it comes down to. If it's still brown and you can't see the bottom of your toilet, you're not quite clean enough. So we want to be able to see through it. It should kind of look like iced tea, or it should look like urine in your toilet. Then you come in, usually about a half hour before your procedure. They're going to meet you, make sure you are who you say you are, check your ID, check your insurance. They're going to start an IV for the sedation medicine to go. Nationwide, 1 or 2% of people choose not to get that sedation, and most of them make it just fine. They have some discomfort, but they make it. But yeah, 98, 99% of people take the sedation, and it's probably not a bad thing at all. So they probably don't have much recollection from their scope at all. They wheel you from the check-in area or the prep area over to the procedure area. A scope about 5 feet long goes in you. Usually it takes a few minutes to go in, and pulling it out, they're really taking their time. They want to pull that scope out over at least 6 minutes, but maybe 20 minutes. The pull out is when they're looking for the polyps in the most part. And then they're going to remove as much gas from you as they can. There are different gases that we use. A lot of places will use air, and in which case they'll remove as much of the air from you as they can during your procedure, but then you're going to have to move the rest of that air later after the procedure. Other places will use CO2 gas, and that's kind of fancy and nice because the CO2 absorbs so fast. So even if they left you with a colon full of gas, it absorbs so fast that you just kind of breathe out the CO2 later. There's not as much passing gas afterwards. And then if you got sedation, you certainly need someone to drive you home. After sedation, you should not be driving yourself. If you didn't get sedation, some people will just drive themselves home. And that's it. Are there any risks from getting a colonoscopy besides perforation? I guess bleeding is one. You know, the chance of bleeding if no polyps have been removed is extremely small. There's not much bleeding from that. But if they're finding polyps, you should be very glad that they're taking out polyps. And then the chance of bleeding kind of varies with how big the polyp is and what kind of characteristics it has. Now, the doctors doing your colonoscopy have lots of ways of stopping bleeding. Some of these polyps are just removed, just literally snipped out. We lasso them with a wire and pull through, and a lot of times those don't bleed at all, and we watch it for 10, 20 seconds, make sure it's not bleeding before we move on. Some of them do bleed with that, and we can inject them with epinephrine. We can put a metal clip on them that staunches the bleeding, and then you'll pass that clip in your stool a week or two later. So probably bleeding is the next one. Some more questions, thank you. Does daily Metamucil intake count as actual fiber? It does. Metamucil, you can pay for psyllium fiber in many ways, but psyllium fiber just comes from, I think it's like the husks of corn, you know, when you're husking the corn and throwing it away. Well, don't throw it away. They take it and process it, and it's called psyllium fiber. It's a very natural fiber. It's very effective. It's great at trapping moisture to keep the stool soft but not too soft and bulky, so they move through and bring the toxins out. So Metamucil fiber does count. I will tell you that dosing matters a whole lot, and probably, you know, a tablespoon or at least 2 teaspoons once or twice or 3 times a day, but most people once or twice a day. Read the label about how many grams of fiber you're getting. A lot of times the pills are half a gram. So many constipated patients tell me, I take Metamucil twice a day. How much are you taking? 1 pill twice a day. Well, they're taking 1 gram of fiber as a supplement. We need 30 grams of fiber. So the dose matters a lot. People who take the pills have to take a lot of pills. So it's the powder, mixing it, and it kind of gets that weird consistency. So you throw it in there, you mix it up quick and drink it fast before it kind of gets that consistency. And is Metamucil safe for long-term use? It certainly is. And Metamucil is kind of the best fiber, and then after that would be like the Citracel type fiber. Citracel fiber is nice because it doesn't ferment. It doesn't give us extra gas that we have to pass. Metamucil can ferment some. Benefiber is the easiest to take. It dissolves in your coffee and doesn't taste like too much, but it's also the least effective fiber. Is ulcerative colitis a risk factor for colorectal cancer? It is. And what are my thoughts about inflammation and gut health in connection? Yeah, so all these conditions that are leading to more inflammation, like ulcerative colitis, like Crohn's disease, we think that's leading to more cell turnover. Maybe more than every 3 days our cells are turning over, and more disordered cell turnover. So certainly the risk of colon cancer increases with the amount of time that you're inflamed. All right. Well, that's our 30-minute. Oh, should you do one more? Okay, I can do one more, Julie's telling me. Is there a maximum age for colonoscopy screening? That is a phenomenal question, and we have to be delicate about how we say that. When you get your colonoscopy, you got pretty good protection from colon cancer for the next 10 years. That's how I think about it. So if I've got an incredibly healthy 85-year-old who's ballroom dancing and who can run up 2 flights of stairs carrying the laundry, that person might want protection for another 10 years from colorectal cancer. So if they come in prepped and ready to go, I'm not going to say no to that person. But if a 65-year-old comes in for their colonoscopy and they really don't walk anymore, they're too weak, they've been losing weight, they haven't stopped smoking despite the home oxygen that they require, that's a much riskier patient to do the colonoscopy on because they do have to be sedated, and it's also a person where they may not have quite as much tread left on the tire. So it's not a year cutoff. It's kind of a health cutoff, and something that you and your doctors can talk about. Okay, this is the last one. Thank you. So outside of high fiber diets, what else can I do to reduce my risk of developing polyps and colorectal cancer? Yeah, so high fiber is great. Activity is very important. Moderation with alcohol is a really big deal. You know, the alcohol issue is kind of interesting. For decades and decades, we were told, and us doctors believe, that a couple of drinks, 1 or 2, is good for your heart. That recommendation has really gone away with better, more focused studies. We don't see health protection from it, but we do see a cancer risk from it, and it's breast cancer, and it's esophageal cancer, and it's colon cancer, and it's multiple cancers, it's pancreatic cancer. So too much alcohol is certainly bad. There are some studies about decreased polyp development with aspirin, maybe going to that inflammatory idea. So people who take a baby aspirin, they may have some fewer polyps, but they will also have less GI protection in their stomach, and they'll have some more stomach bleeds. So I'm not going to tell you to take your aspirin every day, but you can talk to your doctor about taking your aspirin every day. So I'm going to wrap up. We promised to get you guys out of here at 6:30, but thank you very much for coming and hearing and being interested in colorectal cancer screening. We can prevent 80% of the deaths from colorectal cancer, so that's the key point. And I'm Dr. Ryan Carlson, a colorectal surgeon at Cape Cod Healthcare. Thank you.